Hi, it's Dr. Centeno, and thanks so much for joining us today. You've got the power. Today, we've got a really interesting topic, one having to do with pressure headaches and the cause for pressure headaches. Now, usually, when patients with craniocervical junction instability have pressure headaches, they're told it's related to internal jugular vein compression causing intracranial hypertension. Uh, Now, that's hard to prove because in order to prove whether something is causing a headache, you've got to be able to take that headache away reliably. And if it's a structure, that would be treating that structure directly. There is no block that you can do to confirm that you have an intracranial pressure headache. And even measuring intracranial pressure in the standard way with lumbar puncture isn't going to get you there. So it's a theory that they have intracranial pressure causing their headaches. And so today I'd like to throw in another one. We've been seeing more and more patients with swollen upper cervical bursas. So I'm going to go into all of this, what this is all about, where we're headed with this. And then I'm also going to, as usual, start with a short presentation. Then I'll take questions, can be about this topic, can be about any topic. You can ask questions at any time by just putting your question in the comments. So let's get started again. Interesting topic here. And let me go ahead and share my screen. And okay, so a new theory for pressure headaches and CCI is the Bursa a bigger problem than the IJV or internal jugular vein? So one of the prevailing thoughts that you hear a lot of if you treat patients that have craniocervical instability is that if they have a pressure headache that's coming from intracranial hypertension and internal jugular vein compression, and the idea is that the internal jugular vein can kind of get trapped behind, no, it's styloid, but there's a stylohyoid ligament that comes out this way. And the front of the C1 and the C2 transverse processes here. And so compression this way can lead to internal jugular vein compression, and then that can cause some backup of fluids that are trying to drain out of the brain. Now, it's a reasonable hypothesis. There's just one problem. There's not really a way to prove this hypothesis in any individual patient. You can look for things like internal jugular vein compression, but the problem there is that lots of people have internal jugular vein compression and have no problems at all, certainly no pressure headaches that are disabling. And it's not like we can go in and give you a test that confirms this, meaning measuring your total pressure in your spinal column isn't really going to get us there with anything specific. We could float a catheter all the way up here and theoretically check the pressure in this area, but that's rarely done because that has other potential downsides. So there is no real test or block, meaning in pain medicine, if you've got a headache coming from the facet, we can numb up that joint, take your headache away. It's very clear it's coming from the facet. So but we can't do that here. So this is really just a theory about why people have pressure headaches. It's not something that's easily verifiable. So what if for some CCI pressure headache patients, that was the wrong diagnosis? They never really had any pressure headaches related to their internal jugular vein. And so you might ask yourself, well, what else could cause a pressure headache? Now, we certainly know that there are lots of structures up here that can cause headache. The upper neck facet joint, C0, C1, 1, 2, 2, 3, occipital nerves, third occipital nerve, lesser occipital nerve, greater occipital nerve, And that's a short list: superficial cervical plexus, etc. But I want you to think about another possibility, and that possibility is that swollen bursas in the neck may be causing these pressure headaches. And so what we see is that we have these bursas, which I show here in yellow, and here in yellow, that live in front of and in back of the dens. And they act as lubricating sacs to allow C1, C2 rotation to occur. Now, these lubricating sacs are kind of interesting because they're a little different in just about everyone. Sometimes they'll connect in with the left side C1, C2 joint. Sometimes they'll connect from front to back. Sometimes they'll both be connected from front to back. Sometimes they'll connect the right and left C1, C2, or even C0, C1 joints. So their structure is not reported any place in the literature that I can find. So we're actually going to do a study on the structure of these bursas and what percentage of people have which anatomic variation, because that's something we can clearly see when we're doing these procedures if these things connect. Now, what is a bursa? So a bursa is a lubricating sac that helps two parts of the musculoskeletal system move against each other with less friction. So you got part A move in this direction, you got part B move in that direction, and the bursa serves as a lubricating sac to reduce friction between those two. Now, normally there's not a lot of fluid in a bursa, but as the friction goes up, or the banging together of these parts goes up, the bursa swells, which makes it a better lubricating sac on the one hand. So here you've got a swollen bursa in response to that extra fluid. But also realize that the bursa is like a balloon. And just like a balloon that's blown up too much, you can start to feel pressure as related to the bursa. So the most common thing you would see there would be shoulder bursitis. And if the patient has a lot of fluid in that shoulder bursa, the subdeltoid bursa, they're going to feel tremendous pressure in the shoulder. They're not going to be able to sleep at night. It hurts a lot. And one of the ways to take care of that is to drain the bursa, but a lot of times then it just refills because it's filling with fluid because of the trauma in that area. So that's what a bursa is. Now, how would a fluid-filled upper cervical bursa feel? It would feel like a deep pressure headache. It would feel like pressure, which is what it feels like when a bursa is swollen, and a headache because anything that happens in that upper cervical region is going to be experienced by you as some sort of pain or discomfort in the head. So what might this look like on the MRI? So we've got the subtle ones here where we see fluid up in this space above the dens, or we see small amounts of fluid in front of the dens or small amounts of fluid behind the dens. Alternatively, again, that fluid above the dens, but we also see fluid between C1 and C2. Now we can see more than this. Excuse me, this is just the subtle version of what this looks like. Now, that one of those same patients here, this is actually the PICL procedure from that patient. And what's interesting is that we see these bubble structures here and here. Those are fat globules. And it means that instead of getting into the ligament here, we may be getting some of the ligament, but we're getting into more of the bursa. So when these bursas are swollen and we're going below the atlas, we can get into them. And obviously that's not great because what it does is it robs those cells from getting into the damaged ligament. Now, nowadays, we can easily get around that by coming in from above and getting it where we won't get into the bursa. But when we first started doing this and we're only going below, that was a big issue. we would get into these bursas, and now or at least I know what to look for when I'm in that bursa and how to compensate for it. But it is an issue because I think it's also in some patients related to why we have maybe 1 in 4, 1 in 5 patients after a PICL procedure where they have immense pressure type headache pain because we filled that bursa and it's not happy. Now, this one's not at all the second patient here, and this is a patient I had communicated with today. So I told her I'd put her films up here so that we could take a look at this. So we see here, we're marching here from left to right, and these are sagittal slices. You can see the clivus here, and this is a little bit of C2 we're seeing kind of on the side there. And what we're seeing is extra fluid all in here. And then as we march over, we're seeing extra fluid all up in here. And then again, as we march over, extra fluid all up in here. And then as we march over, extra fluid all in here. And now we're actually into the C0, C1 facet joint. And there's actually bone reaction here and fluid within the joint, indicating an effusion within that joint, meaning swelling that extends directly into the C0, C1 joint. Now, my guess is we're seeing it that way because she probably has a 0-1 joint. And actually, I'm sorry, this is the left. So my bad. This was right to left here rather than left to right. A left C0, C1 joint that communicates with this swollen bursa. And what's interesting is when we did the PICL patient on that person, we went below, we saw this, which is filling of the C1, C2 bursa. So we were able to compensate for that by coming above. We got nice ligament flow. We ended up getting good transverse alar flow, etc. But many years ago, had we only done this, A, I wouldn't have recognized that this was the bursa, and B, we wouldn't have had a way to get around it. And it would have just been a bursal injection. Obviously now it's far different once we're using 2 C-arms, and I've had hundreds and hundreds of patients to get to the point where all of this can be recognized and quickly adapted for. But it is interesting because it fits with that idea of this bursa being there, it being fluid filled in these patients. And also realize that the thickened bursa on the backside of the dens is what causes a pannus, right? So you've probably heard that a pannus can put more pressure on the upper cervical brainstem here, or brainstem and upper cervical spine or spinal cord. And this is that bursa. In addition, we see fluid in the C1, C2 bursa there as well in this particular patient. So realize that a pannus is made up of this bursa as well. So also, as I said before, realize that these bursas can connect to each other front to back. They can connect with each other left to right. They can connect with the C1, C2 joints. They can connect with the 0-1 joints. They can connect the 1-2s and the 0-1s. So we're going to start a study here probably this next week on just recording these connections and how often these sorts of anatomical variants are found, because I can't find the literature that anyone else has published on that at all. So how would we prove this theory? Well, this next year, I'd like to prove it. It's right now a theory, and unlike the intracranial hypertension theory where you really can't prove it, this one we could prove. We could actually inject a numbing medicine into one of these bursas and see if it takes the patient's pressure headache pain away. Now, realize that when I first started doing this work with PICL and inventing this procedure, coming the front like this, we didn't know how risky that was. Now that we're getting close to 1,000 PICL procedures, and we'll probably punch through that somewhere in January, we now know that the risk matrix is far, far less, and I would feel comfortable in the right patient who had disabling pressure headaches doing this type of block to see if it's the bursa that's causing that pressure headache. And because it's a theoretical thing, I don't think I'd even charge that patient to do this kind of block to rule in or out their pressure headache. But it's got to be the right kind of patient who has disabling pressure headaches, maybe a patient that's already tried PICL and the pressure headaches really didn't change, trying to see whether or not there is, in fact, a swollen bursa causing that pressure headache. So in summary, the upper cervical bursas are quite real. You can see them on MRI. Obviously, they're described in the anatomy textbooks, as I've been showing you anatomy pictures. They can be seen inflamed on MRI, everything from subtle to not so subtle. And I believe they can cause pressure headaches. And I'd like to prove this theory sometime early this next year to start performing some diagnostic blocks and also publish a paper on that, as well as the normal variation in these bursas, because there's all sorts of anatomical variations out there that patients have. So thanks for watching that. Let me get to questions. I'm going to go ahead and get out of here, and we will go to some questions. Looks like we got a bunch. Sarah, so I have post-concussion symptoms, head tight all the time. Great, Sarah. Good to know. Let me know if there's a question I can answer there. Ulysses, which prolotherapy works? Is it 25% or 50% dextrose? 25% is too high. The most common prolotherapy dextrose solution would be 12.5%, which is more than enough to make prolotherapy work. If you go too much higher than that, and again, the biggest problem is prolotherapy solution getting around nerves. If it gets around nerves, that's a bad day for everyone because it can kill the nerve. Now, if we bring that down to 5% just hypertonic dextrose, not prolotherapy solution now, that's relatively safe around nerves. But at 12.5%, that can injure nerves, and the higher you go, the more likely it is to injure nerves. You don't really need to go higher than 12.5% to get it to work. Dana, what's the difference between a bursa and a pannus? How do we see a bursa on imaging versus pannus? Which one affects PICL or posterior PRP? As I was showing you there, bursa and pannus, the bursa that goes behind the dens makes up a pannus. So one of the bursas is what we call a pannus. Now, that can be fluid filled, or it can just be very, very scarred down from lots of chronic inflammation, and then it turns into just a part of the pannus. Ulysses, every time I lay down in bed, especially with my neck and flexion, I keep hearing my own heartbeat. What does that mean? Well, that's a common thing that happens in lots and lots of different people, not unique to CCI. So could be nothing at all, might mean something, but difficult to say that for sure it means something. Now, if we look at internal jugular vein compression symptoms, let me see if I can open that window and I can find that for you guys. Let's see here. One of these has some of the published symptoms for internal jugular vein compression. Here it is. Okay, so I'm going to share this here. This was a study that looked at internal jugular vein compression that was symptomatic, and then they obviously went ahead and got from patients what the most common symptoms were. So these are the symptoms of confirmed internal jugular vein compression. The bigger the word, the more likely that is being relayed as a symptom. So insomnia is number one. right up there with tinnitus, then head noises, then hearing impairment, then headache, then neck pain. So those were confirmed internal jugular vein compression cases. And let's stop the share. Submitted advanced by fat chin. I did my first AO adjustment, which held 4 days. That's good. My head tilt that I have had since I was a teen was normal for a few days. So less lumbar pain and a bit more upright time. Is there a point? Try one and wait for PRP treatment. Well, if your first AO adjustment gave you dramatic relief, I'd probably continue with AO adjustments at this juncture, meaning that I don't know why you wouldn't just continue with that before even trying any neck injections at all. My overall sense would be ride that horse as long as you can ride it. If you went back a second time, for example, and you got a week, and you went back a third time, you got 2 weeks, and you went back for a fourth time, and you got a month, then that may be all you need. It would only be if they couldn't get it to hold more than 4 days after repeated times that you would consider injecting the neck or doing anything like that. Lissy, can the DEN C1 articulation be injected, or is it inaccessible? What do you do to help someone with degeneration in this joint? I'm not quite sure which articulation you're talking about here, Brian. Are you talking about a cervical facet joint, C0, C1, C1, C2? Or are you talking about where the DENS meets the atlas up front, in which case that would be that PICL procedure would be the only way to access that. Obviously, if it's the facets, those can be accessed from the back. Submitted advanced by Fatchen is an issue to a CT venogram before posterior PRP procedure. It isn't, but it's pretty invasive, meaning that you would only do a CT venogram if you thought that you had internal jugular vein compression and you were going to act on that information, meaning that you'd be exposing yourself to huge amounts of radiation by doing a CT. Now, there are certainly patients where we've done that in, where we really believe they've got internal jugular vein compression and there's no other way to help them. So they might be considering something like getting that decompressed. But it wouldn't be a study that I would do just for information, because internal jugular vein compression on CT venogram is common. It's common in people that don't have symptoms. So once you get that information, what are you going to do with it? That's the way I would look at it. Ulysses, does CCI cause vertebral artery dissection? CCI can lead to vertebral artery dissection, but that would be an extremely rare complication of CCI. And all the CCI patients I've seen through the years, I've only seen maybe 2 of those out of thousands. So it's out there. It's just not super common. Fatchen, my AO Cairo mentioned in my report the term vertebral subluxations and said that my C2 is 12 degrees rotated and C1 tilted right is consistent with AI. All of that's consistent with AAI, but again, those are more terms used by the chiropractor to set vectors to try to adjust it back into a good position. Let's see which ligaments in the neck are important the most. I'm not clear on that question, meaning that they're all important. There's no extra ligaments. There's no extra spare parts. You need them all. Submitted advanced by Fatchen, does a higher blood coagulation factor, APTT, fibrin D-dimer effective PRP procedure. If you've got a coagulopathy, now again, diagnosed by a board-certified hematologist, then that's something that the doctor would definitely need to know about, because normally those patients, it's not going to so much affect a PRP procedure as those patients need to be treated with certain things before they undergo any type of procedure that breaks the skin. Now, if we're talking about functional medicine stuff, I don't do that. So here we'd have to be talking about diagnoses made by a board-certified hematologist. Fatchin, can posterior PRP injections help with C1, C2 rotation, or PICL is better suited for that because it targets more ligaments that hold C1, C2? That's going to be more PICL for that kind of instability. Ulysses, can neck instability cause loss of range of motion of the neck and both shoulders along with muscle spasms, right? Sure. It's been advanced by Stacy. I, like many CCI patients, develop tinnitus. In the last few weeks, I've also developed intermittent but increasing days of nasty, sharp inner ear pain in the right ear, which is the more pain-riddled side of my CCI pain, and intermittent dull ache in the left inner ear. Yeah, I mean, there's a couple explanations that could be. You could be getting cranial nerve irritation. You also could be getting irritation of the temporoauricular nerve right back here, which is pretty common in patients with TMJ. The temporoauricular nerve goes back here and then up into the ear area, and then the temple, hence the name temporoauricular. So that's also something else that can cause that kind of thing. Omega-3 okay to take for PRP posteriors. It's a blood thinner, so I would stop it for at least 2 or 3 days prior to, and then go right back on it after. But it's a blood thinner, not like a prescription blood thinner, but it will cause some excessive bleeding. Sarah, what about cranial massage? What's the injection? I don't know what you mean by that one. Ulysses, blind injection safe for hip, SI joint, and back. Does it have blood vessels, nerves in that area? Blind injections are below the standard of care in 2022. It's just that simple, Ulysses. So no, not okay. It's below the standard of care. In fact, it was a blind low back injection that cratered prolotherapy. Prolotherapy used to be very common back in the 1940s. There was even a prescription drug back in the early days of pharma called Sanusol that was manufactured for prolotherapy. And all it took was some yahoo who didn't use guidance, because no one used guidance back then, that stuck a needle intrathecally, meaning into the dural sac, and injected and paralyzed a patient, and that permanently. And that's what cratered prolotherapy. Prolotherapy then died a horrible death in the 40s. It wasn't resurrected as a treatment until a generation later in the 80s. And so, no, all blind injections in the spine are absolutely positively below the standard of care in this day and age. So you shouldn't be injecting any of those things without, at the very least, ultrasound guidance. And for most structures in the back, you would need fluoroscopic guidance. So like I told you before, this is not the area to be looking for a deal. Look for a deal when you buy a car, look for a deal when you go buy a TV. But in this area, if you're looking for a deal, you're looking for trouble, because a deal comes with, I don't really know how to do this, and I'm just going to stick the needle somewhere in there. It's been advanced by Stacy. Recently, you answered my question about where to inject for the rotating C2. Many of us have. You mentioned 2 or 3 places, but I can't quite make out what you're saying. Are you able to please show? Well, the biggest issue, Stacy, for that type of really common C1, C2 rotation, here, let's go back, see if I can find this. Hopefully I can. Okay, so this is a good blog to read, Stacy. It's a good primer on this whole topic. Why the C1, C2 facet joint is inherently unstable. So the C1, C2 facet joint is a biconcave joint. So that means that you've got one concave surface sitting on another. Very different than a concave convex joint, like a hip or a shoulder, where you've got it locking in like this. here you've got the opposite, right? And I can never do this right with my hands on the camera, but you've got a concave on a concave surface. And if there's any instability, one's going to fall down the other one, and that's going to lead to rotation. Just like that. So that happens due to weak ligaments and muscles. What ligaments are responsible for holding all that together? Alar, transverse, accessory, etc. Now, if someone has rotation for a different reason than just general laxity of the upper cervical ligaments, then you can go ahead and try to differentially tighten things like the posterior fascia in the back of the cervical muscles on one side that hook into the spinous processes. Usually that's associated in someone or with someone who has scoliosis and a side bend in their spine. Yep, did that already. And the treatment is getting rid of the thing that's causing the bursitis, in this case, stabilizing those ligaments. Next round of PICL data. Not for a while, Diana. Let's see. We've done 2 rounds of PICL data. The first round was maybe 2 years ago. The last round was maybe 3 months ago, something like that. Now, I don't know if I did a formal presentation. I ended up releasing some of the PICL data results when I was traveling. So if I haven't done a formal presentation on that data itself, then please remind me of that, and I'll be happy to do that on one of these Facebook Lives. If I recall, I released the second batch, more just telling you what it showed. And there was 2 big things we were looking there. Number 1, is this still working? The answer was yes. Number 2, is there a big difference between EDS patients and not? And the answer was no. But I am happy to go ahead and share that in more detail with you, looking at all the data points, all that kind of stuff, if I haven't done that. And I just don't recall because it was during that time I was away. Lizzie, is PICL covered by insurance? Not covered by group health insurance. If you're one of the 800 companies or with one of the 800 companies that are covered through Regenix Corporate, then there is coverage through your health insurance plan. So I see you're in the police department, or at least you get a police department badge. For example, we've got coverage for a lot of the fire stations. So a lot of the fire guys have full coverage for something like this. As to whether or not your specific municipality is, I don't know. I think I just answered that one. Can you continue to do chiropractic after getting prolotherapy injection? In general, yes, but if you're getting a prolotherapy injection from someone in particular, you got to ask that doctor that, because I don't know specifically what it is they're doing. Diana, what makes the diagnostic blocks above C2 safe versus dextrose, which is neurolytic? Yeah, I wouldn't put dextrose in any area that might go around the nerves. So I think what you're describing is if we were to put, for instance, dextrose in a place that got around the C2 nerve, for example, C2 spinal nerve, that would cause a chronic permanent headache and nerve injury here. So we wouldn't want to do that. That's why we use guidance. So if we're going to put it in the C1, C2 joint, we're making sure via contrast that it's going in the joint. And then I don't even use dextrose in joints. I would use platelet-rich plasma, which if it got around the nerve would help the nerve, not hurt the nerve. But you bring up an excellent point as to what I said before, and that is that 12.5% dextrose prolotherapy is neurotoxic, meaning it will destroy nerves, and it destroys the myelin sheath around the nerve. So you wouldn't ever want to put that anywhere around the nerve. And that's, again, the rationale for what we've been talking about here today, right? You want to use guidance. You want to make sure you know where that stuff's going. You want to make sure you know where that stuff isn't going at all times. Rigolab, have you ever treated the stylohyoid ligaments or the infrahyoid muscles, tendons, ligaments that go along the larynx thyroid cartilage with injections for hyperlaxity? We have injected the stylohyoid ligaments and the stylomandibular ligaments for severe TMJ laxity, because one of those jacks into the mandible. As far as injecting infrahyoid tendons, ligaments, all of that's doable. It would not be something that would be hard to do. The question would be, why are we doing it? And is there a clear rationale for why it should be done? And what's the risk benefit of doing it? Stacy, can this pressure from the bursa just make you feel like cerebellum is being crushed, or does it only cause pressure feeling on top of the head? Stacy, I don't know what cerebellum being crushed feeling is. That's not one that patients generally, or that's not a descriptor that patients generally use. What they'll tell me is, they've got head pain here or here or here, or their whole head feels like it's got pressure, or they'll tell me that they've got a burning sensation here or hypersensitivity here. Those are the kind of things that I'll generally hear from patients. But cerebellum being crushed is not a common one I hear. Bethany, could the swollen bursa cause the pressure in the frontal lobe and face like sinus pressure? I have pressure all over the head. We squeeze my eyes and forehead, release. I can feel the fluid pressure move. Well, Bethany, the first thing we first need to rule out common things. So the first common thing that would need to be ruled out is a sinus infection. So assuming that someone knowledgeable has ruled out a sinus infection there and sinus pressure itself, then as far as squeeze my eyes and forehead, don't know what it is you're describing there. I think what you're telling me is when you squeeze like this, it helps. And the question is that moving fluid, or are you stabilizing your head on your neck? It's hard to say. Connor, when I bend over, I have a horrible sensation. All the vertebral segments are lifting off each other. When I come back up, they all slide back together. Yeah, that's hard to say, Connor. That would be, something really good to look at on a DMX to see if we can see exactly what's happening. Will pannus decrease in size after PICL? If the pannus is due to active fluid in that bursa that's behind the dens, and we can get rid of the instability, it'll decrease in size. If the pannus is from years and years and years of abuse of that bursa with fibrosis, meaning scarring of the bursa, then it's probably not going to change in size afterwards. Again, one of the reasons why I always tell patients to get these diagnoses early, because obviously when I see someone that's been like this for 10 or 20 years, the likelihood that you're going to see changes that are irreversible goes up. In thoracic. Okay, Connor. Well, we're not going to be able to do a DMX in your thoracic spine, so that would have to be a clinical diagnosis. Liam, I'd have to review all of your stuff to do that, and probably not good practice for me to discuss these sort of individual patient things on a public forum like this. So certainly just email me. I'll take a look at your imaging and tell you what I see, but more in private. Corinne, if you had success treating tinnitus that is not caused by hearing loss, but maybe part of TMJ and cervical stenosis. Well, cervical stenosis doesn't really cause tinnitus, so we'll cross that one off the list pretty easily. TMJ generally doesn't cause tinnitus, so we'll cross that one off the list. So then we got to figure out what's really causing your tinnitus. Now, tinnitus can be caused by lots of different things. It could be, we don't know, can be related to, let me stop my share here. Can be related to internal jugular vein compression, can be related to general upper cervical instability. We've seen it in all of those instances. It can be related to inner ear damage, etc. So, but TMJ and cervical stenosis wouldn't be on the list of things that cause tinnitus. What is a bursa? A bursa is a lubricating sac that allows two things in the body to move against each other with less friction. Do you think at some point you'll be draining bursa during PICL? Probably not, because it would require using a bigger needle, increasing the risk for damage. Now, if we see someone who clearly has an awful lot of fluid in there, then we would use a bigger needle, which would be a 22 rather than a 25, and probably take the additional risk. But on a routine basis, no, it just would add risk. It's far better to let the fluid go down on its own. WW Soft. Why do some transverse occipital instability, C1, C2 overhang greater than 3 when head tilted left to right, do okay with prolotherapy to Hackett points, posterior capsule against whereas others do not? Yeah, I haven't seen many patients do well with a lot of C1, C2 overhang with posterior injections. What I tell patients is that certainly give it a shot from someone who's not just blindly sticking needles back there, but is doing it under guidance. And in my experience, it's a 1 in 5 or less that really respond and get to the next level by just doing posterior Hackett points that way. So there's not many patients I've seen that respond well there. In fact, our rate was so dismal, we stopped offering it, meaning we always used to do posterior prolotherapy type treatments and or facet injections, the both, in patients who had C1, C2 overhang. And the results were so dismal, meaning only 1 in 5 or less were falling out at that point after a couple of treatments, that we just stopped offering it and just went directly to PICL. So is it possible? Sure. If you just keep scarring the snot out of all this stuff, you might get a little bit of help. But, those are clinics that, I don't agree with the treatment plan, meaning that I don't believe you should ever bring a patient back routinely for 8, 12, or 15 or 20 injection-based treatments in a row. You should be using procedures that get the patient better much more quickly than that. So yeah, if you just keep beating the snot out of it, maybe you'll get more people than 1 out of 5 to respond, but we haven't seen it. In fact, those clinics serve as a great referral for our clinic because patients get 8, 12 of those types of injections, doesn't really work, or they're a little better, and then we're right back to square one. My biggest concern with that situation is that they've blown an awful lot of money on procedures that have a very low success rate for that problem. And then some of them are just tapped at that point. They don't have any more money to spend on anything else that would probably work much, much more reliably. Fatchin, is it not possible to see or inject the bursa with posterior approach, right? No, I don't think we'll get into those bursas. Now, the one caveat would be if the bursa connects into one of the facet joints. And we see that, like I said. So if you had a bursa that connected to C1, C2, you could drain it through C1, C2 posteriorly. But again, that's going to take, number one, someone that has done hundreds and hundreds of those procedures, someone that's got digital subtraction angiography, because now we can't use the normal 25 gauge needle, which is smaller. We've got to use a bigger 22 gauge needle. And a bigger 22 gauge needle just means more damage if it's put in the wrong place. Meaning it's about 3 times the width, 3 times, 2.5 times, something like that, the width of a 25 gauge needle. So if a 25 gauge needle gets put in the wrong spot, less damage. A 22 gauge needle gets put in the wrong spot, which you would need to drain, much more damage. So that's definitely one that would need to be done by someone that does hundreds of those a year to reduce the likelihood of any injury to that patient. Liam, after PICL, my neck was very inflamed. It felt good actually. Unusual neuro symptoms were greatly reduced. 3 days after PICL, inflammation has gone down a lot. My neck range is all back to pre-procedure baseline. Is it normal? Yeah, that's a good sign, Liam. So what you're describing there is that honeymoon effect. So the honeymoon effect is when things are swollen, everything feels pretty good because the ligaments are tight. So that's a it's good news for me because it means we're on the right track. And it's also good news that it didn't last 2 weeks, meaning that for some of our patients with chronic low-level systemic inflammation, that honeymoon period will last 7 to 14 days. It's good for the patient, right? Because they're feeling great for 7 to 14 days. But it's not good on the scale of systemic inflammation, meaning that if someone can turn inflammation around in 3 days, that's a much healthier individual with low-level systemic inflammation who's much more likely to get better quickly. But if someone's got a 2 or 3 week honeymoon period, it's great for the patient, but it means that they've got high levels of systemic inflammation in their body, and that's not helping anybody, meaning it's not helping that patient. So that's a patient that's going to be much tougher to treat. So congratulations on turning that inflammation around really quickly. Dr. C, what is a nerve fiber dissection? What is sought after outcome from nerve fiber dissection? Yeah, all a nerve fiber dissection means is that we're trying to place helpful platelet growth factors around the nerve. And to the extent that the nerve might be scarred down at that spot, trying to get the scar tissue off the nerve. So it's injecting around the nerve. The outcome would be much less nerve pain from the nerve we're talking about. Read your blog about the regenerative occipital car wash. Can you explain more about what to expect someone from our occipital neuralgia? Let's see. Is there a blog on that one? That's a good question. Jennifer, I've done so many blogs at this point. I think I'm up to around 3,000. So at some point, I don't remember them all, but let's see if I did one on a car wash. Okay, so let's share this. Okay, so we have the lesser occipital nerves out here, the greater occipital nerve here, the third occipital nerve here. The usual place that those nerves are treated are at the skull here or here. And the third occipital nerve goes way down here at the side of C2-3. So obviously, you can treat these along the skull base. That would be the usual place. You can treat the greater / third occipital nerve. Down here, it's called third occipital nerve at the side of C2-3. That's an X-ray guided procedure. But you can also treat this tissue plane that lives above these upper cervical muscles. And that's what we call, that's not a medical term, we call it a C2 or an occipital nerve car wash. So it's just treating those nerves at another spot. So again, is one more effective than the other? They're really for different patients. When the nerve is getting entrapped at the skull, then that would be the most effective place to inject. When the nerve is getting pissed off by these upper cervical muscles, then you can inject in that car wash tissue plane. Or when the nerve is getting irritated at the side of C2-3, you can inject the third occipital nerve down here. So they're all just different strategies for different patients. I think I answered that one already. Yes, Ulysses, I've heard of Dr. Hauser in Florida. And I think, the good news is what you'll get at Dr. Hauser's clinic is very simple posterior prolotherapy. And they don't use guidance the same way that we would use guidance, meaning we would use guidance with contrast to confirm we're in a place. They're using guidance just to do simple Hackett points. So that's sort of this simple posterior prolo. The good news is that if you had something like instability at C2-3 inflection, that may be all you need. But if you've got atlantoaxial side-to-side instability, like we've been talking about, not going to do much in my clinical experience. Bethany, does having a bursa affect the successful outcome of a PSEL, like for the second patient you showed on your presentation? Bethany, we don't really know. I can tell you what I think it has done traditionally. Traditionally, many years ago, when we first started to see these patients with these enlarged bursas, and I'm talking now going back to 2017, 2018, we were only really going below the atlas. So that was a big problem, meaning that we were getting in the bursa more often than we're getting in their ligaments. These days, that's all been corrected by advancements in the procedure. So we can now come above the atlas and go down, staying out of the bursa. So based on that, I would say no, it probably doesn't. But where I'm trying to do some investigation is, are these the patients that have fairly severe pressure-like head pain after the procedure that lasts for the first several days, simply because that bursa was pressurized during the procedure? But as far as successful outcomes, no, I don't think it'll make a big difference with today's procedure. Back in 2018, it would have made a huge difference, in my opinion, with the outcome. In fact, one of the reasons why I developed and pioneered going over the atlas, because we wanted to make sure we were staying out of the bursa if that person had one. Diana, can TMJ injections of PRP help stabilize the hyoid bone in place? Well, it's all part of the anterior stabilizing mechanism. So let's see here. What's a good picture to show you? It's probably a good one. So the hyoid bone is down in here, and you see that there's these anterior strap muscles going up and down, and then you've got the muscles that go from the hyoid to the mandible directly. So if you had mandibular instability or TMJ instability, stabilizing the TMJ could offload some of the extra forces on the hyoid, because these muscles down here in really severe TMJ instability can spasm, because they're going to be a secondary stabilization mechanism for the TMJ. Rigolab, can a mild form of CCI or upper neck inflammation that cause tinnitus also cause tingling of facial nerves, tongue, and pressure in the sinuses? Not sure what you mean by a mild form of CCI. But in CCI patients, trigeminal neuralgia type symptoms or tingling of the nerves of the face, that's cranial nerve 5. When you say facial nerve, it generally means cranial nerve 7. But I think you mean tingling in the face itself, the face nerves, and that would be trigeminal nerve. The tongue is cranial nerve 12. And that also can be pressure in the sinuses. So if we look at cranial nerve 5, cranial nerve 5 goes into the sinuses. So the maxillary division here goes into the sinuses. So innervates the face as well as the sinuses. So pressure in the sinuses can be irritation of cranial nerve 5, or a manifestation of trigeminal neuralgia. Now, normally that goes away when we stabilize the upper cervical spine, but if it doesn't, we can also treat the trigeminal nerve as it's coming out of these spots with that same nerve hydrodissection. Lacey, can prolotherapy help with scoliosis mild curve? Not really. You can do differential tightening under image-guided and that would be more advanced image guided type ligament injections. We call that a scolioplasty. I probably have about 5 minutes before I have to go, guys. Let's see here. If you look at scolioplasty, that would be a good way to find information on that. So if you go to the Regenix site, Ulysses, and just type in scoliosis, it'll come up as to what scolioplasty is and how that works. No formal presentation, more so a quick review of EDS comparison. Okay, yeah, so I'll try to do that. I think that got lost in the shuffle when I was overseas and then came back. W just saw any information about the related complications for old style Prolo, ultrasound, and fluoro guided on the neck. Also really wish I could ask more of a certain popular neck clinic in Florida. Or ask about a certain popular neck clinic in Florida. You're certainly willing to ask me anything about any clinic as far as rated complications for old style Prolo. Nope, it's never been reported as far as I know. So I don't think you're going to find any reports there. I can just tell you from personal experience, if you're not using guidance, there's a risk of hitting something you shouldn't. And that just is what that is. And what is the risk? I don't think anyone knows what that risk is. I can tell you what I hear. We hear stories from patients all the time where we know that nerves were hit because they felt a certain zap and then had chronic pain in that nerve after old style Prolo. But no one's published on any of that yet. And I doubt you're going to see it because you've got the old style Prolo guys just weren't into publishing anything. And then you've got the other guys, ultrasound and fluoro guided specialists, few of which offer prolotherapy. I suddenly have my whole body cracking and I don't have another disease. I feel it is related to my IIH, which related from Bursa. Whole body cracking wouldn't have anything to do with if you're talking about intracranial hypertension, then no, it wouldn't have anything to do with that. Mark, I got restorative sleep following adjustment, my rotation. Is it common to get restorative sleep after adjustment? I would certainly think that you would sleep better and deeper if you didn't have pain or discomfort coming from your upper neck, for sure. Thanks, Mark. Okay, guys, I know I've got a bunch more questions here. In fact, I got more than I can see right now, but I do have a hard stop at 2 for a meeting, so I can't go beyond 2. So thank you for all these questions. They were great. And I want to make sure that I get to them. So I'll be here on Monday, and we'll do all of this at 1 p.m. Mountain Time, 3 p.m. Eastern Time, 12 noon Pacific Time on Monday. And I'm happy to answer these questions if you come back. I'll also try to see if Carol can copy and paste some of these and maybe just submit them so that they're on the next video. And then I did promise someone I would get Dustin to send me all the specific EDS data so that we have that. And I'll do a presentation on that. I'm not sure if I'll get to that on Monday or if that'll be the following Friday, but I'll try to get to that. So I apologize. Okay, guys, thank you so much for watching and have a great day.